Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Kevin Speer.
Thank you and welcome. This is another of the Healthy Focus series of monthly discussions and seminars for the general public of varying topics. Tonight's topic is an orthopedic topic. It's a musculoskeletal topic. It's a topic on the shoulder. And I'm an orthopedic surgeon, so that's where my medical background comes from. And we're going to talk tonight about shoulder pain and trying to deal with it and live with it. Something we talk about, or I entitle the Shoulder Owner's Manual. So tonight's talk is going to be a lot about the topic of pain, to hopefully not be too cute, but I hope it's not a painful talk for you. But it's about pain because in it we're going to talk about a lot of features of the shoulder. And people say, well, what about bursitis, and what about tendonitis, and what about bone spurs? And that's all part of the discussion, but ultimately the reason that people are interested in bone spurs, or you're interested in tendon tears, or you're interested in bursitis, is because it hurts, because it's painful. If it weren't painful, I doubt that there's this searing curiosity within you to say, I want to know more about the shoulder. So what makes the shoulder hurt? Well, basically living life and being active is what makes the shoulder hurt. It's using it. And generally speaking, you're painting this with a broad brush, that not using the shoulder is a pretty effective way of not experiencing pain. It's just that many people decline to accept that, or that's not a very good option, or they don't like that. The only real remedy is to stop doing things because they want to do things. Certainly pain at rest in the shoulder is always more symptomatic. So generally we're talking about pain that occurs with activities, but sometimes pain can occur without activities. And what I want to focus on here at the first part of the talk is try to explain something that many of you may have experienced. Certainly patients who get pain, but not necessarily in the shoulder, but in other parts of the body too. It's why does the shoulder hurt more at night? Why do you get night pain? Well, there's several contributing reasons. One is very mechanical, in that certain sleep habits make the shoulder pain worse, meaning, rolling over on the shoulder. As an orthopedic surgeon, as a clinician, talking to patients, my patients who are there to see me in the office, I'm very interested in pain at night, because usually pain at night that distorts sleep, that disrupts your sleep-wake cycle, is highly motivating to seek a remedy. I mean, some people, it hurts during the day, but at night they're okay, because most of all of us have figured out, beyond that which has been discovered through research, is that sleep and the amount of sleep and the quality of sleep is integral to good health, especially as we get older. So sleeping habits that make it worse, rolling on the shoulder at night can make it worse, which is sort of not uncommon because it's like someone punching your shoulder. It's just laying on it. It's pressure. Another reason the shoulder can hurt worse at night is the position of sleep, that you're lying flat. Most patients, or most people, if you have an ankle that you've sprained and it hurts and it's swollen, it's throbbing, generally speaking, most people intuitively know, you get off your feet and you elevate above your heart, much better. Why? Well, you get the ankle above the heart, the hydrostatic pressures, and the pressure to swell is less. Same thing's for the shoulder. But to get the shoulder above the heart, you got to have a more upright torso. So a lot of times people learn, either through trial and error, that sleeping in a recliner, sleeping in a lazy boy helps. All the patients that I operate on that's where they sleep after surgery, because getting the shoulder up helps. So laying flat can be an issue. Certainly to go to the third one, the other reason the shoulder can hurt at night is overwhelming pathology. I mean, serious problems. Large rotator cuff tears, a cancer, an arthritis. That can make the shoulder hurt at night. But the other reason the shoulder hurts at night, which is more germane to our discussion tonight, it's more of how the brain perceives pain, something called the gait theory of pain. And this is, I hope you find this interesting, because a little bit is the physiology of pain, but it really hopefully will explain to you, hopefully, observations that you've had about why things hurt at night. Because many times in patients who have symptomatic shoulders that I'm seeing in the office, in which they're making the decision to have an operation, for the majority of people, not all, but the majority, it's the relief of night pain. They're saying, my shoulder bothers me, but the pain and problems I have during the day, I can live with that. It's the pain at night that drives them. So the reason our shoulder hurts at night has a lot to do with the way God made us, the way we're wired up. And to sort of make it simple, if this is sort of messages to the brain, so which means how we perceive pain, that comes through the spinal cord, and you get lots of input, like the various pain nerves and other nerves that go to the level of the spinal cord, and then not all of them reach the brain. Meaning, if at the same time on my forearm, you poked me with a pin, tickled me with a feather, put a cold pad here, and put some heat here, I may not feel all four of those at the same way, because they're all combined together. They're all going up together. They crowd in the spinal cord, the gait, and not all of them reach the brain at the same time. So that's what the gait theory is that multiple sensations coming from the same area of the body can sort of cancel each other out, so the brain doesn't perceive everything. Now this is somatic, meaning musculoskeletal, bones, ligaments, tendons. This is not gallbladder pain. This is not kidney pain. This is not heart pain. This is orthopedic pain. This is musculoskeletal pain, bones, joints, the limbs, the arms, the shoulder, which is what we're talking about today. What's interesting about the way we are created is that the sensory nerves, those are the nerves that perceive the impulses into the brain. So we touch something. Is it hot, cold, sharp, dull? Does it hurt? Does it tickle? The nerves that carry pain are the teeniest little nerves. And the nerves that carry the other stuff, temperature and vibration, are bigger nerves. They're thicker nerves. Now, for those of you who say, why are they thick? Well, they have more what's called myelin. But all you remember is that the bigger nerves, the thicker nerves, carry the other sensations, and only the smallest, tiniest nerves carry pain. So what that means is that when the bigger nerves win, it's a little bit like football, the bigger you are, the better. I played college football, and why not, right? I'm big. I was bigger and heavier than everybody. So, it's like, football is a lot simpler and easier. If I'm 40 pounds bigger than everybody else, what a deal. At least it was that way till I got into college. So think of the way the pain works like that. So here's a picture of inside of a man's thigh. It has these TENS units, pads, like vibration pads you can use, or a product called Icy Hot, which you put on, you feel this hot sensation. It could be capsaicin powder or whatever. But that sort of heat or counter friction rub or vibration, when the body experiences that, the brain experiences at the same time, there's pain underneath it. For some reason, the pain part gets nullified. So why do TENS unit work? If you have a TENS unit on, like from physical therapy, it's because vibration trumps pain. to an extent, So meaning so if you have a TENS unit on and it's vibrating, it's like, oh, I feel the vibration. I know. So you're either going to feel vibration or you're going to feel pain. So vibration generally is a more pleasant sensation than pain. That's how pain is perceived. So the gait theory of pain really is, so say the back of this man's shoulder, he's putting a cold pad, so he's chilling the back of the shoulder, or this, quote, cold therapy, which isn't cold therapy really, it's just like, icy hot, but Bengay, which you put it on and it feels, it tingles, right? It stimulates. It's like, oh, it's deep cooling. Well, that's not true. Because it can't go that deep. Our skin is remarkably good insulator. Remarkably good. It takes a lot, even with cold therapy, it takes a pretty chilled application to get more than maybe 2/3 of an inch deep, 2 centimeters deep. So, but the reason that this works is that if you're getting some ache in the shoulder, say you have bursitis, and you put this Bengay on, and all of a sudden your shoulder, you feel the Bengay, it's all tingly. From the brain sensation, that tingly trumps pain. So, the reason the shoulder hurts at night is that all these crowding, competing stimuli are not there. You're laying there and you're quiet and you're trying to get to sleep. There's no other competing influences. The brain isn't actively distracted. So it's like the pain is always there, but during the day, other things can block it and crowd it, and at night, there's nothing left to crowd it. Because if you try to crowd it at night, it'd be hard to sleep. So anyway, that's sort of how, that's why things hurt at night, is that at night, everything else gets peeled away, and all you're left with is the core sensation that maybe the pain. So how does pain work? Well, pain in the shoulder is mediated through inflammation. So it's an inflammatory problem. Now, it could be inflammation of the bursa, bursitis, or the tendons, tendinitis, inflammation of the joint, which is the synovial lining, called a synovitis, or you could have a destructive process in the joint that then becomes inflamed, and arthritis. So what will make the shoulder hurt? It's quite simple, really, in the shoulder, is that usage demand exceeds supply. So, the amount of supply the shoulder has, what it's capable of, is inadequate for what you just chosen to do. And the result is the stress accumulation in the shoulder hurts. So making the shoulder not hurt, which is sort of largely the tease of the talk, how do you live with it, without shoulder pain? So how do you make the shoulder not hurt? And these 3 bullet points are largely what the rest of the talk is going to be sort of divided into. And there's 3 strategies, 3 areas of different thought. One, decreased demand, making a lifestyle that works. Another is treating the symptoms. We'll talk about that. And the other is increasing the supply, which means if the demand is greater than the supply and your shoulder hurts, you can either decrease your demand, increase the supply, or treat the symptom itself. Or you can do 2 or 3 of the above. Decreasing demand is common sense. It's moderating your activities. It's modifying your activities. Many times I have patients say, well, can I exercise, yes or no? Well, it's not a yes or no answer. It's yes, but. You can exercise, but there's certain things you shouldn't do. Can I play golf? Yes, but. What does that mean? Well, it means maybe you can't play golf 5 days a week if that's what you in a perfect what you want to do. So it's not a matter of can you do something yes or no. It's not an on and off switch. It's more of shades of gray. The credo of activities as pain permits is apt here. It really is. It really is. But part of what decreasing demand means is that you've determined what hurts. you've moderated or modified your activities, and you're willing to be accepting of that. I mean, much of the realm of clinical problems in the shoulder that I deal with have everything to do, well, one is the patient's informed decision on what they want to accept. You know, how moderate are you willing to accept your lifestyle? How restrictive do you want your activities to be? Because if you restrict them enough, you can make your shoulder not hurt, and that is wonderful. You can avoid surgery, you can avoid treatment, life is simple. But you may find that boring, or unfulfilling, or unsatisfactory. Well then, you have to consider some other strategies. One of them is getting more engaged in treating your symptoms. Pain in the shoulder, mediated through inflammation. Treatment of that is an anti-inflammatory strategy. Fortunately, the two best anti-inflammatory medicines to deal with shoulder-based pain happen to be over the counter: ibuprofen and naproxen, Advil or Aleve. Given a choice, if my patients ask me, I like Aleve. The reason is you get more bang for your buck. Aleve lasts about 12 hours. Ibuprofen lasts about 6 to 8 hours. So if you take Aleve twice a day, you can cover pretty much a 24 cycle, which is good. If you're going to go Advil, which is fine, you got to do more 3 times a day. If you want to take it to cover a 24-hour cycle, but in terms of efficacy and strength and safety profile, they're both very good. Now that's assuming you can take anti-inflammatory medicines. You know, what's the most common side effect? It's heartburn, stomach upset. So if you have reflux or you have some GI problem, you may not be able to take that. Or if you're on blood thinners, well, that's too bad. And I try to share that. So some patients have problems that are not that severe, and their pain is not that terribly bad. And if they could take simple medicines, God, life would be simple. But they can't take anti-inflammatory medicines. That is too bad. So you are withheld a very easy symptom, or a very easy treatment for the symptoms. Other anti-inflammatory strategies is cold. Cold is wonderful in the shoulder. Cryotherapy. It controls the pain, as you talked earlier through the gait theory. And there's enough of an impact that it can control some inflammation. It can be anywhere from cold pads or sometimes these bag of frozen peas, or like a bag of frozen corn, big old 2-pound ones, and you sort of smack it, and it just sort of conforms to the shoulder. It's hard to put an ice bag up there, and you don't want to put an ice bag up there because applying cold to the skin is not without risk. Cold you have a thermal injury to the skin. You can have frostnip. Just like too much sun, you get a little sunburn or a redness. Too much cold do the same. And ice is too hard. Ice is too intense. You need something that's not ice. Something that will warm as the skin and the body heat it back up. So like a freezer bag, a bag of frozen corn or frozen peas, I think works wonderfully, and it's safer. The other symptomatic treatment, now you have to go to a physician for this, is a cortisone injection. And in a few minutes, I'll sort of talk to you what the bursa really is. But the grand central station of pain in the shoulder, especially the degenerative shoulder, the older shoulder, is the bursa. You get a bursitis. Now, there's maybe 30 different reasons you can get a bursitis in the shoulder, but ultimately, you got a bursitis. And once you get it, putting cortisone in that bursa can be very helpful. It can be helpful. Now, what are reasons that you shouldn't get cortisone? One, if you're diabetic, don't get cortisone because the cortisone can distort and will distort your diabetic status. How much? If you're lucky, a little. If you're unlucky, a lot. And how do you know? You don't. So don't do it. Even though it's effective, it's very effective. The problem with cortisone is it wears off. But if you're having some symptomatic flare-up and you're miserable and you say, gee, I need some relief, that is a wonderful strategy. Also, other anti-inflammatory strategies is an antioxidant diet, which is basically a healthy diet. But, fish with omega-3. So it's a discussion of omega-3 fatty acids. My gosh, they are beneficial. I'm a big believer in them. Fish, berries, nuts. You can supplement yourself with fish oil. There's more and more things, and they're good for cholesterol. They're good for the brain, and they're good for the heart. But they're definitely creating a more antioxidant chemistry in your body. Means your body is a little bit less prone to developing inflammation so easily. And a lot of people develop inflammation easily. An extreme example of that is a condition called fibromyalgia. That's what that is. I mean, there's a lot of reasons that you can get it and a lot of challenges with it, but it's that for a reason the body just inflames so easily. So if you have a body that is more resistant to inflammation, some of that it could be the way you're made and your healthfulness, but also what you eat matters. So what you eat matters. The third component of dealing with a shoulder that may hurt and making it pain-free is increasing supply. So we talked about decreasing demand. We've talked about treating the symptoms, and now increasing supply. And generally, this is the arena that you're seeking help, because this is what shoulder treatment is. I mean, decreasing demand, usually through common sense, trial and error, you figure out what hurts, and for someone to come to to see a physician like myself, and and they say, oh, you have all this expertise, and I say, well, the way that you're going to make that shoulder stop hurting, you just got to stop playing golf. Well, you're not there. You're not seeking that kind of professional expertise to be told that by not doing something is the way to treat it. You say, you want to do something. You want to be active. You want to do things. And you got to increase the supply, increase the capacity of the shoulder to do things, which means making the shoulder better. The shoulder has to be made better. Now that takes intervention. That takes treatment. That takes thought. That might take physical therapy. That might take exercise. That might take stretching. That might take the services of an orthopedic surgeon. But that is an actively engaged process. It's enabling the shoulder to become more vigorous and more doable and durable, and ensuring it's going to do what you want it to do. And not just for 2 hours, maybe for several hours, several days a week. So the tenets of improving the shoulder are improving the strength, improving the motion, and improving the anatomy. And this is how we're going to finish the last sort of third of this talk. But because part of the intuitive process is again decreasing demand. You can get. Hopefully you've got that mostly figured out, and you found that unsatisfying. You want to do more. Taking medicines and treatments are good. Some people are opposed. Some people can't tolerate it. But the solution, the durable solution, is to get a shoulder that simply is better. It functions better. It is better. And to make it better, you can get it better, stronger, better, more limber, or just better, meaning better anatomy. And we'll get to that last. So improving strength is exercise. There are 22 muscles that work the shoulder joint. And we'll have a little brief anatomy lesson coming up. So you have to suffer through that. But there's 22 muscles that work the shoulder joint. And the shoulder has 2 layers of muscle. There's an outer layer and there's an inner layer. The shoulder is all about muscles. And it's muscle strength, muscle coordination, muscle activity. And as we get older, muscles get weaker. And you've got to strengthen the shoulder. The shoulder responds wonderfully to applied strengthening. It can be on your own. It can be with a trainer. It could be with a physical therapist. Whatever. A lot of patients get really tripped up and, well, what's the best exercise? Tell me what's the best one. And I would say there is no best exercise. Just do something. Whatever. You can work with weights or sport cords or whatever you want to do. Anything more than nothing is good. Now, because some exercises hurt. Some people, if you have a bone spur in your shoulder and some bursitis that you're prone to, and you go to the gym and think you're going to get your shoulder stronger by doing overhead lifting? Well, you won't do that very well. Why? Because that doesn't work well. So you have to learn. If that learning process is through a trainer, great. Especially if you have trainers in gyms that have a sensitivity or training or an awareness to treat clients who are not 20 years old, who have degenerative conditions, who probably have a little stiffness, who probably have a little wear and tear on them, and if you can find a trainer like that, they are immensely valuable. From my perspective as an orthopedic surgeon, I'm a huge advocate of physical therapy. I believe in it, and there's not a consensus in orthopedics. Many of my orthopedic colleagues do not feel the same. I think physical therapy is important because they have a largely educational role. I mean, they take you through your paces and they do your exercising and all that, but part of it is figuring out how to exercise, especially at a shoulder that's painful, because generally a painful shoulder, a shoulder is painful enough to come to see a physician like myself, are not easily exercised. They hurt when they do things, and I'm saying, the solution to this is we're going to exercise you. So, intuitively, it doesn't make sense. But clinically, it's a very sound strategy, but it has to be done thoughtfully. And, giving someone some sheets and say, here's some exercises and go do them, that works not often. Improving motion. The shoulder has more motion than any other joint in the body. The most motion of any joint in the human body. And as we get older, there's predictable tightening. Now, generally, the tightness comes in the back of the shoulder. It's more internal rotation. You might sense that if you're trying to reach behind you for whatever you reach behind yourself for, and you're like, God, it's tight. Yeah, that's tight. What does that mean? That means you're not 20 anymore. That's what it means. Now, but the shoulder, if it tends to stiffen more, that stiffness brings in problems. And so, when I tell patients or people they need to exercise, you also need to stretch. Or you need to stretch to assure yourself that your motion's great. Just stretch just to stretch. And usually a stretch is a nice warm-up too. It kind of warms the joint up and all that. So I think stretching is extremely important in the shoulder. Another adjunctive effort, and like I was in clinic today and I must have told 10 different people this, take advantage of the summer. Especially if you have a painful shoulder and you want to find a way to, how do I exercise my shoulder? I don't want surgery, but it hurts and all that. But you're willing to do something. Seek water, find water, exercise in water. It works. Tremendously beneficial for the shoulder. In water, the arm weighs 1/8 of what it does on dry land. The buoyancy of the water. So normally, if I'm standing in water, so I'm pretty oversized. My arm probably weighs 25 pounds. The average arm probably weighs 15 to 20. So if I'm standing in water, and the water is above my shoulder but below my chin, and I'm ready to move my arm in space, so my muscles, which aren't affected by the buoyancy, what my muscles in my shoulder are seeing is an arm that weighs about 3 to 4 pounds, not 25 to 30 pounds. So why? Because it's in water. So all of a sudden, if you want to exercise, but you're going, God, but it's so sore, it's so weak. You need a forearm. So how do you exercise a shoulder that's so weak or painful, you really can't deal with gravity? Do it in water. At least in the summer. My God, you can have access to water. And as hot as it's going to be this weekend, you would be well served to be in water. Increasing supply for the shoulder. So improving anatomy. Now this is where we get into that it's going to come down to, for you to do what you want to do, and for you to be as active as you want to be, that getting it stronger, you've efforted, and you are stronger, but it's not good enough. Getting it limber, well, you have stretched, and your motion is pretty good, but it's not good enough. And you are willing to take some Advil or some Aleve, and it does help, but it's not good enough. So then, and you simply don't want to accept the limitations your shoulder faces, then you got to improve your shoulder. And that's improving anatomy. And so here we get into our little anatomy lesson for the night, because the shoulder has unique challenges, because the shoulder deteriorates as we get older. Perfectly healthy person and all. And the best analogy, and I think a very apt analogy, is like this. Gray hair. What does that mean? That means you're not 20 anymore. That's what it means. I mean, so how gray? Well, maybe, everyone gets gray. Maybe a little gray, maybe a lot gray, maybe it's white. But everyone gets some gray. That it is influenced by two things, age and genetics. Period. Now the shoulder has a third factor that comes into play that makes it age too. Wear and tear. Cumulative wear and tear. It could be your job, the physicality of your life, injuries, accidents, things like that. But it's called senescent change. The shoulder has predictable degenerative changes as we get older. Just like the neck, just like the lumbar spine, the low back. Those three areas predictably age as we get older. Now, other parts of the body, maybe the elbow, maybe the knee. I mean, the knee can get some spurs, but that's more arthritic process. This is the shoulder, it just happens in the shoulder as a phenomenon of getting older. And what happens? Bone spurs form. Bone spurs are the edge of a bone that should normally be smooth outgrows a sharp edge. And the best analogy is if you take a pin and you deploy the edge that right, it becomes a sharp edge. So the cervical spine, the neck, forms spurs, and when they get into problems, what do? Well, the neck, they pinch nerves, and it hurts. You get pinched nerves, nerve pain, radiating pain, sometimes numbness in the head. So in the neck, spurs pinch nerves. That's why the neck causes pain. In the shoulder, spurs pinch tendons. That's what happens in the shoulder. And that dust up causes bursitis, tendon problems, tendon deterioration, and tendon tears. Also, as we get older, the muscles weaken. Much of that is hormonal, age-based, especially in men, testosterone. As the testosterone level drops, the muscle trophicity, as they call it, the muscle capacity, the muscle strength drops. Bones soften. Phenomenon of age, much more so in women. Again, why? Hormonal. So it can be addressed to some extent, and genetics plays a role. The anatomy of the shoulder, all this mischief in the shoulder occurs deep. So, as I said earlier, the shoulder has two layers of muscles. There's an outer layer of muscles. So if you look at yourself in the mirror, you just got out of the shower, what you see is the outer layer of muscles. In the front, the muscle on the side here is the deltoid. Muscle in the front, the chest muscle, is the pectoralis. In the back, if you look in the back of the mirror, it's the trapezius muscle in the back. Those are the muscles that are power. Those are the muscles that lift, push, pull, carry, drive, make that you're working to get stronger. These are the muscles, and tendons connect muscles to bone. These are the muscles and tendons. These don't deteriorate as you get older. These are just fine as you get older. Now, they may weaken because of hormones and things like that, but they don't predictably deteriorate. It's the inner layer of muscles that all the mischief occurs. The inner layer of muscles, in their collective, is called the rotator cuff. And again, tendons connect muscles to bones. So there's 5 tendons deep connected to 5 muscles that are a shroud around the humeral head. Here would be the humeral head. So the shoulder is a ball in a socket. So like a ball here. Here's a socket here. The glenoid is the socket. So muscles in the front, they happen to be called the subscapularis and the supraspinatus. And in the back, called the infraspinatus and teres minor. But collectively, they form this hood around the shoulder. Unfortunately, some orthopedists 70 years ago called it a cuff. It would have been more correct visually and structurally called a hood. But it's called a rotator cuff. And the top of the rotator cuff, this muscle right here, softens, deteriorates, and tears as we get older. By age of 70, about 1 in 4 people have a tendon tear there. even if their shoulder feels fine. There are different studies that show different prevalences and all that, but I think 1 in 4 is pretty reasonable. Which means it may be that no matter what you do, and you may be the best, most dutiful patient ever, some of this is pre-programmed, and much of that has to do with the actual age, how much wear and tear you've had, and your genetics. And genetics plays a greater and greater impact as we learn more and more about it. So putting that together, you got the ball here and the socket here and all the muscles. Then between the rotator cuff and the bone above, this little blue thing here is the bursa. Now a bursa in a body, think of a bursa as an empty balloon. So anywhere in the body that moves. So when I raise my arm up in space, tendons in the shoulder are next to the bones and they're gliding past one another. Well, they don't naturally glide. There has to be a relatively friction-free membrane in there. So think of it like an empty balloon in there. So there's bursa anywhere in the body in which one tissue rubs over another tissue. Otherwise, there's friction, and friction hurts. But bursa are remarkably dynamic structure, which means if you can get them inflamed and they can flare up and they settle down. They wax and they wane. Some bodies, you can be painting and overdo it, and your shoulder can hurt terribly for 2 days. Oh my God, I have a tendon tear, and this is awful. And you rest it for a couple of days and take some medicines, and in 2 or 3 days, it's better. Why? Because what you did, you flared up the bursa gets worse, bursa gets better. So it's a very dynamic structure. But this is where the bursa is located in the shoulder. And unfortunately, so here's the humeral head again, and the bone on the top. These spurs form. There's little like sharp hangnails, sharp edges, and they irritate the bursa. So the bursa hurts, and you form bursitis, and you got the whole sweeping problem that emerges from it. And if the spurs bang on enough, the tendons start to tear. And the reason this is important is it may be that your problem, so you have pain reaching and pain with golf and pain with certain activities, you have a bursitis that keeps recurring. Yeah, you've strengthened it, and that's a great thing. And yeah, you've stretched it, and your shoulder's covered. That's a great thing. And yeah, you've taken some Aleve and Advil, and it does help. The problem is the source of your bursitis, the underpinnings of your bursitis, is mechanical. You got a spur beating on your bursa that you cannot escape from. It's like having a rock in your shoe and saying, "Well, it hurts to walk." Yeah, I know it does. So how do you manage that? Well, you can walk less. You can walk different, or at some point you got to get the rock out of your shoe. So once these spurs form, and everyone gets spurs, everybody gets spurs. We all do. No one does not get spurs. So it's a nice double negative for you. But how big the spurs get? Genetics. How big the spurs get has a lot to do with your activities. If your neighbor is retired and he was a bricklayer his whole life, I bet he's got huge spurs. And the neighbor on the other side was an accountant his whole life, relative, his job demands were more modest in terms of physicality of the shoulder. He may not have such a big spurs. So a lot of this is cumulative wear and tear, lifelong. Once it is determined that the source of your problem is mechanical, I mean, yes, the problem is bursitis, and yes, you've treated it, but you cannot get rid of it. Why? Because there's a spur pitching on it, because there's a tendon tear as part of it. Well, then you have a mechanical problem. The symptoms you can treat, but you cannot escape the mechanical problem. And the problem with tendon tears anywhere in the body, but especially the shoulder, they don't heal. Not without surgery. So that's the challenge. How much of the problem is dynamic and physiologic from weakness and stiffness, and how much of it is mechanical. The more mechanical your problem is, the more mechanical your solution has to be. What's a mechanical solution? Activity avoidance. What's a mechanical solution? Activity change, activity moderation. Don't do that which hurts. Change it. What's another mechanical solution? Fix the anatomy. I mean, that's what orthopedic surgeons do. So when someone is treating a shoulder, and I say orthopedic surgeon, and you say, well, how do you know when you need surgery? Well, you need surgery when all the treatments short of surgery have failed. I mean, you've tried to get it stronger, it's not good enough, and you get it limber, and and all that, and you're unwilling to live with it. So all this comes into play because bone spurs never go away on their own. The tendon tears don't heal. The tendon tears don't necessarily get worse. So if someone has a small tear and a spur, and their shoulders are pretty well controlled, but they're still hurting them some. You're not saying, I don't think your shoulder's going to get much worse, hopefully, but it's not going to get much better. It is what it is. If you can manage this at this level, you're good. And if this becomes inadequate, then you need a better shoulder. You got to consider other solutions. I don't mean this to be self-serving, but I think that seeing a physician to make a diagnosis of your shoulder is important because treatment, prognosis, all measures of answering your question in the shoulder center on a diagnosis. So it may be that your shoulder hurts. Yeah. Well, what can I do? Well, is your tendon intact? Yes or no? You have a spur? Yes or no? Your motion, your joint. I mean, all these variables stratify into certain answers. And so, to get an answer, you need more information. Because I'm a big advocate in informed consent. And I think I want patients, people who aren't patients, to make decisions based on information about what they should and shouldn't do with their shoulders, based on knowledge, not just guessing. Yeah, I got some bursitis, and I think I'm okay, and all that. And then all of a sudden, they've had it for, 5 or 7 years, and finally it gets bad enough that, God, it's killing me. I got to get it treated. They see their medical doctor. They say, well, you got a lot of pain there, and it sure is weak, and now that it's finally hurting you, let's get an MRI or something to assess it, and they get an image and say, oh my Lord, you have something that's not even fixable because it's been deteriorating for all these years. So I think making a diagnosis is important. Could be from the primary care physician, the PA, chiropractor, orthopedic surgeon, physiatrist. But I think diagnosis is key because from diagnosis comes prognosis. If you want to know what your options are and what you can expect from those options, tell me with precision, anatomically, what's wrong with the shoulder. And then you'll know. Because here's an example. So imagine, so here are x-rays. And this just shows somewhat, standard x-ray, that's the ball and the socket. But what's important, so imagine someone says their main problem is that they like to paint, and they're up here, and God, it aches, and it's so sore up there all the time. So what does that mean? Well, they could have a stiff frozen shoulder that might need stretching. Or the rotator cuff tendon may have a tear to some extent, and that might need strengthening or something else. Or you get an x-ray, and all of a sudden it's arthritic. Well, that's a problem. That's a problem in the sense that this is not going away. So if you're in the mood to say, gosh, what can I do to get this better? Not much. Not much, really. I mean, you can stretch it some, you can take some medicines, but to live with arthritis, that's a real problem. But at least you know that it's a problem. That's what I think is important. I think you should know it's a problem. You should know that this isn't going to get better. You might make it symptomatically better, but living with an arthritic shoulder, especially that's this arthritic, I mean, here's the humeral head, the socket, almost all, nearly bone on bone. That's a problem. Or you get an X-ray, and so here's the humeral head, and see this little white cloud here? That's a calcium deposit. Well, that's something altogether different. So it may be that by exam you got some bursitis, but by X-ray you have a calcium deposit. Well, if you have a calcium deposit, you might as well go into a different room for treatment because it's a different problem. And sometimes the ineffectual treatment are things you're trying to do to get your shoulder better. One reason it may not be getting better is that it's just not getting better. I mean, you got a problem that's just not getting better. But another reason it's not getting better is you're doing the wrong treatment. Your treatment is misguided. Not deliberately, but just because lack of knowledge. You have misjudged the nature of what's wrong in your shoulder. And if you really want to figure it out, it's an MRI. MRIs are superb for the shoulder. Superb. Here's a ball, the humeral head, and here's one of the rotator cuff tendons coming down, and then you have this sort of white gap with an arrow applied. Well, that's what a tendon tear looks like. It's a gap. It's a hole. The tendon is not complete. There is a hole in the tendon. Okay? So what does that mean? That means it's going to hurt. That means it's not normal. That means it has a deficiency. That means that there's going to be some limitations. It doesn't mean you have to have surgery, but it means it's not normal either. So you have to be aware of that. So I think, again, all this comes to making a diagnosis. Don't just imagine it's going to be better. Architecture, I think around the turn of the early 1900s, coined the term that form follows function, and that was the credo of architecture. In the shoulder, it's the reverse. It's function follows form. The shoulder will take you as far as its anatomy allows. So if what the anatomy is, so part of it's genetics. If you're doomed to get big bone spurs, well then that is unfortunate. Because that means you're going to have more problems than other people when you get into your late 50s, 60s, and 70s. If you're prone, if you're not prone to it, that's great for you. Good news. If your life course has taken you to a job that's a lot of wear and tear, it's physical, a lot of physicality, not injury, just physicality. It's a physical job. Extrapolate over time, it's going to hurt. But at some point, it's just a matter of accepting what the shoulder can do and doing it. Because as you know, getting old is not for the faint of heart. So stuff hurts, and at some point you can get stuff better and all that. And at some point, if every single thing that hurts were to sort of slow you down or stop you, you may not make much motion. So keeping active is the key to staying active. I believe that strongly in the shoulder. Babying the shoulder, limiting yourself excessively isn't going to be good. Abusing it and beating it up defies common sense. But you got to stay active in finding things that work. It's making good informed decisions. It's making good choices. It's making it's trying not to make the same mistake twice. So much of it is trial and error. You've done something and you didn't imagine this thing was going to hurt, and afterwards it hurts. And and that you're self-aware enough to say, man, I got to figure out a different way to do that. Or you decide to paint a room and you have 2 more rooms to paint, and after the first room, your shoulder's hurting you. Well, your shoulder is not liking that repetitive activity. So at some point, either the light's going to go on to say, I better rethink the other 2 rooms, or you're going to consign yourself to a lot of pain when you go the other rooms to start painting again. So it's making good informed decisions. And much of it is living without shoulder pain is trying to align what your shoulder can do and what you're able to do with the goals. If you can get your goals, or I can get my patient's goals aligned with what their shoulder is capable of, that's great. And it may be like maybe like this woman here, something trivial like exercising with 1-pound weights every other day, and that's what she wants to do. Good, because her shoulders won't do much else. But for her, it fits. Now another patient, with this much activity moderation, they went, oh no, I want to do more than that. All right, well then that involves other considerations. But it's setting your goals, understanding what you want to do, and then understanding what it takes to do it, and then making the informed choice. Are you willing to do it? Are you willing to commit yourself to the level of effort and pain to some extent? Because exercising and therapy for painful shoulders is not without pain, but it's your choice. It's the patient's choice, and with that, I think comes people who can set goals and achieve goals, and generally try to get shoulders that they're happy with. You know, a shoulder that simply has not much pain and that they can live with, and they otherwise don't need to fuss with or seek professional attention for. At least we hope. Thank you.